Good afternoon, Fair Lawn Ambulance Corps. This is Dr. Jonathan Barr back again for episode 6, and this time we're going to tackle chest pain. Before we get too far into it, please take a look at the disclaimer, take a few moments to read that. And since it is the day before Thanksgiving when I'm recording this, I specifically chose chest pain because, you might be eating a lot of salty foods or maybe drinking some alcohol when you celebrate with your friends and family these next couple days. And so one of the things that I can teach you guys about is something called holiday heart syndrome. Often this refers to cardiac problems resulting from lots of salt, lots of alcohol intake. People have a lot of dietary indiscretion around the holidays. And this can sometimes actually lead to arrhythmias, frank arrhythmias. Most common is probably atrial fibrillation. So something to look out for out there. If you pick up any patients, they've been eating, drinking a lot, now they feel palpitations, they feel their heart racing, they feel chest pain. Maybe they've got this going on. So in the spirit of Thanksgiving, we'll talk about the heart today. Now this is probably the single most important slide I have here, and I want you guys to memorize this list. There are 6 main life-threatening causes of chest pain that you need to be aware of in EMS. They are myocardial infarction or a heart attack, pulmonary embolism or blood clot in the lungs, aortic dissection, which is tear in the wall of the aorta, tension pneumothorax, which is a collapsed lung, cardiac tamponade, which is fluid around the heart, and Borehave syndrome, which is esophageal rupture. Again, that's myocardial infarction, pulmonary embolism, aortic dissection, tension pneumothorax, cardiac tamponade, Borehave. I'm going to say it again using abbreviations: MI, PE, dissection, tension pneumo, cardiac tamponade, Borehave. Memorize it, repeat it to yourself, listen to me repeat it to you, because this is an important list for you to know, and you don't want to ever miss one of these patients when you see them in the field. Now, what is a myocardial infarction, commonly referred to as a heart attack? In its simplest possible terms, it is essentially a blockage in one of the arteries, called coronary arteries, that provide blood flow to the heart. Most common cause of this is that people accumulate plaque in their arteries over time throughout their life, and then you can get a plaque rupture, which can lead to an occlusion. You can also have other types of occlusion, but to keep it simple, something blocks the artery, the heart muscle no longer gets blood, the heart muscle begins to die, and dying heart muscle is never a good thing. And this is a time-sensitive condition, so it's important that you recognize this and get these patients to a cardiac center where they could potentially be revascularized. Now, what are the symptoms of heart attack? I have here a slide showing symptoms of heart attack in men and women, and this gives you somewhat of a classic description. So typically you'll get the classic description, right, if you read the textbook, is chest pain that radiates to the left arm. Although the chest pain, the classic crushing elephant on my chest pain that moves to the left arm, that was really kind of figured out when most patients were, white male World War II veterans. And society today doesn't consist entirely of white male World War II veterans. So your patients may present atypically. I would in fact say that more often than not, they will present with atypical symptoms. And so anyone who has chest pain and is really sweaty and is diaphoretic, you should be worried about them. If they have pain in their neck or jaw, not just their chest and arms, but neck or jaw too, be worried about them. If they're having trouble breathing, if they say, oh, it's just heartburn or indigestion, you should be worried about them. And women are even more likely to present atypically. Sometimes they'll describe back pain or pain between the shoulder blades. Again, the gas and indigestion pain. Keep that in mind. Holidays coming up. Oh, I just have indigestion. I was eating food. Maybe, maybe not. Okay? So you always have to really think about, could this be an MI? And do I need to get them to the hospital where they could have an EKG and cardiac enzymes to really tell if it's an MI or not? So really don't miss this. This is so easy to miss because patients will try to rationalize their symptoms. Like, oh, I just ate too much turkey. I was having too much. I just have some acid reflux or indigestion. And that might be true. They might have that. But they could also have an MI because remember, MIs can present atypically. They can present like this. And so you need to be aware of it so you can counsel the patient appropriately and say, hey, we really should just make sure that this is nothing serious. We recommend you go to the hospital, get an EKG, be seen by a doctor, maybe get some cardiac enzymes. And you don't even have to know that they need EKG and enzymes, but you should say they should be seen by a doctor because this could be potentially a life-threatening condition. Now, To understand this lecture, we're going to have to throw back to episode 2. Remember our lecture on shock? And we talked about cardiogenic shock. So one of the main ways you get cardiogenic shock is if you have an MI and part of your heart muscle dies and can no longer pump effectively, you now end up in cardiogenic shock and you can't supply your organs with blood. And this is a really dangerous, life-threatening condition. And so just to bring it back, remember your cause of shock. We talked about problems with the pump, the pipes, and the content in there. This is a pump problem, right? The heart can't pump well enough. And so remember that this is MI can be a cause of cardiogenic shock. Now, what about aortic dissection? So this is another cause of chest pain that's life-threatening. Essentially, what an aortic dissection is a tear in the intimal wall of the main blood vessel, the aorta, that supplies the rest of your body with blood. And so the kind we worry most about is the type A dissection, which are the one you see on the left. Type B also needs to be addressed, but is a little bit less dangerous. Both of these need to go to the hospital. Both are dangerous and life-threatening. From your perspective in EMS, if you suspect aortic dissection, you need to get that patient to the hospital, okay? Now, when are you going to suspect it? How will you know? So typically aortic dissection patients often have high blood pressure. They may have recently used cocaine, which shot up their blood pressure. They can have a ripping or tearing sensation often. And you really want to think about aortic dissection when you're thinking about what I call the chest pain plus syndromes. So if you have chest pain plus abdominal pain, or if you have chest pain plus a neurologic deficit, if they say, you know what, I have arm numbness in addition to having chest pain, you should immediately think aortic dissection, okay? And you should be worried about that. When you do your physical exam, if you feel the pulses and you find unequal radial pulses, you should worry about aortic dissection. If you find a blood pressure differential, that their blood pressures are unequal, it should make you think aortic dissection. And any patient who says, oh, by the way, I have a past medical history of Marfan's or Turner syndrome or any other connective tissue disorder, you should, and now they have chest pain, you should think about aortic dissection because the tissue in the aorta is a little bit weaker, and so they're more prone to it compared to others. And so those should be signs that should tip you off that maybe there's an aortic dissection going on. Now, what about pulmonary embolus or PE? So if you look at this CAT scan image here and you see the gray part there, that's actually representing a blood clot in the lung. It's actually obstructing the pulmonary artery. Now, obstructing pulmonary artery, we talked about previously, remember throwback, episode 2, can lead to obstructive shock. Now, and which is, again, a life-threatening condition. So when do we have to think about a PE or pulmonary embolus? Well, one is if they've had one before, or if they've had a DVT, which stands for deep vein thrombosis, which refers to blood clots in the legs. Anyone who's traveled, so been on a long plane flight or had prolonged sitting. So remember, people are going to be traveling a lot for the holidays. They're going to be sitting in cars for a long time, maybe plane flights. You start to think about this if they come in with chest pain and shortness of breath. If they have one leg that's more swollen compared to the other. History of cancer. So cancer is a prothrombotic state, meaning cancer will cause blood clots. And so anyone who says, oh yeah, by the way, doc, I have breast cancer, they say, oh, by the way, sir, I have breast cancer, and now they have chest pain and shortness of breath, you should be worried about pulmonary embolus. Anyone who has recent surgery is also prone to clots, especially if they've had surgery to repair a hip or something like that, especially orthopedic surgeries. Anyone who uses hormones, and this includes birth control. So patients on birth control are more likely to get blood clots than patients who are not, or hormones for any other reason, such as hormone replacement therapy, or maybe people who are transitioning from one gender to another may be taking hormonal medications. And in that case, you should think about PE if they develop chest pain. Also, anyone who's prolongedly immobile. So think about this as your nursing home patients. Maybe patients that you pick up from a local nursing home. They sit in bed all day. They can't really get up and move around. Those people are more likely to develop these clots. Let's move on to cardiac tamponade. So as you can see in the picture here, what cardiac tamponade is, it's fluid that builds up around the heart within the pericardial sac. Now, this fluid causes obstructive shock by preventing the heart from pumping properly. It obstructs the outflow of blood. Remember, throwback to episode 2 if you need a refresher on obstructive shock. So how does this happen, or when should you think about it? So one would be penetrating injury to the chest. Someone stabs the heart, and now blood fills the pericardial sac. So that's one way. The other way would be, again, history of cancer. Remember, your cancer patients, malignancy here, that just means cancer, okay? Your cancer patients can develop malignant effusions around the heart, so they can build up fluid there. Patients who had an MI recently, you should also think about this because maybe they're now having a complication of their MI and having free rupture of the left ventricle, and that can lead to blood accumulation and cardiac tamponade. Anyone who's recently had their chest instrumented, maybe there's a little nick or tear. Let's say they had a pacer in and maybe one of the wires eroded through the heart wall, and then they can develop this. Your patients on dialysis can also develop pericardial effusion. So those are patients where you might start to think about this if they have chest pain, and you might start to worry about cardiac tamponade. Moving on to tension pneumothorax. This is another one of our life-threatening causes of chest pain. Anyone recognize this photo? If you do, you should recognize it because, again, we talked about this in episode 2 when we were talking about, again, obstructive shock. And so what happens in this case is the lung collapses, causing a shift, the mediastinal shift you see here in the photo, which compresses the heart and, again, prevents outflow. So to refresh, we just recapped from episode 2 the types of obstructive shock, which can be caused by 1, massive pulmonary embolus, 2, cardiac tamponade, or 3, tension pneumothorax. Okay, so it starts to come together why these are the life-threatening causes of chest pain, because they lead to shock. Now, when should you think about tension pneumothorax? So basically, any traumatic injury to the chest, you should think about it. It could be blunt or penetrating. However, it doesn't have to be due to traumatic injury. It can also be spontaneous. So who is at risk for spontaneous pneumothorax? In theory, it could happen to anyone. But if you want a description of the person who get it, you want to think about it in your young, tall guys who smoke cigarettes and recently had a change in atmospheric pressure, such as getting off a plane, or maybe they came from a concert where there's loud music. That can change the thoracic pressures and lead to tension pneumothorax. Now, how are you going to find this on physical exam? The classic way is to listen and hear either decreased or absent breath sounds on one side. But I'm going to tell you a different way, and what I think is a better way, and that's to use a technique called tactile fremitus. I want you to feel for tactile fremitus. Now, what is that? So, like I was saying before, the classic way people teach the diagnosis, at least when I was in EMT school, was they taught you to listen with your stethoscope, and if you hear decreased or absent breath sounds, then you should be worried there's tension pneumothorax. Honestly, in all practicality, I think that method is mostly useless in the pre-hospital setting, because there's lights and sirens, there's people yelling, there's people screaming. It's incredibly hard. People wearing clothes. It's incredibly hard to listen accurately and really determine that there's no breath sounds. And sometimes you can get confused because you'll hear transmitted breath sounds from the opposite side of the lung, and you can miss this very easily. So in the pre-hospital setting, I would actually recommend you use tactile fremitus. So what is tactile fremitus? Tactile fremitus refers to the vibrations in the chest wall as a result of sound that goes through the lung tissue. So essentially what you're going to do is you're going to feel the patient's chest wall. It's easiest to feel this on the back. And so you're going to take your hands and you're going to place it on the chest wall. I use it like a karate chop maneuver like this, and I feel on the chest wall, and then you're going to ask the patient to say a phrase. Now the phrase I use is 99, so feel free to use that. You're going to say 99, and the patient will say 99, and you'll feel the vibrations in your hands. And then you'll move up and you'll say 99 again. 99 again, 99 again, all the way up the lung. What you're feeling for is asymmetric vibrations on either side. So with tension pneumothorax specifically, you're going to feel decreased fremitus because there's excess air in there, and that air is preventing the vibrations from transmitting through to your hands. By contrast, let's say the patient had pneumonia and there's fluid or consolidated lung in there, which is more of a solid lung. That will actually feel like increased fremitus because sound will travel faster through that solid tissue than regular lung. So again, tension pneumothorax, decreased breath sounds, decreased fremitus. Now, this is another photo just showing the possible techniques you can use to feel the fremitus. I use the method shown in photo C, but you can also use B or A, which is the one on the left. So I said this earlier, but I want to do a little bit of spaced repetition just so you guys remember this. In episode 2, we talked about causes of shock. And in this lecture, a lot of them come up again because these are, again, like I said, the life-threatening causes of chest pain. So cardiac tamponade causes obstructive shock. Tension pneumothorax causes obstructive shock. And thrombosis, I use a T here just to help you remember it, which thrombosis in this case is referring to a pulmonary thrombosis or pulmonary embolism, which leads to obstructive shock. What kind of shock do you have if you get a thrombosis in the heart? Cardiogenic shock, right? So again, these life-threatening causes of chest pain lead to shock, which kills patients. Now let's talk about the last cause of chest pain that's life-threatening here that we're going to talk about today, which this one is a little bit probably more out there for most of you, but it's something called Borhave syndrome. Borhave syndrome essentially means esophageal rupture. You rip a hole in the esophagus and the esophageal contents spill out into the mediastinum. This is incredibly life-threatening, very high mortality. Now, you'll see in this graphic here, Borhave syndrome is depicted on the right. There is a more minor version of this with a more minor tear called the Mallory-Weiss tear, which isn't completely through the esophageal wall. Both of these situations are going to arise in patients who repetitively vomit. And this is often patients who have been drinking a ton of alcohol and are, ton of vomiting. It's Friday night. Maybe they're out there, they are celebrating their Black Friday deals this week. They had too much to drink. They're hanging out with their friends. And now they're repetitively vomiting. The vomit gets bloody. And now all of a sudden they have incredible chest pain. And when you feel their chest, you feel all these Rice Krispie-like sensation there. If you get this patient this weekend, you should be worried about Borhave syndrome. The other patient population to consider this in is patients who've had a recent manipulation of the esophagus. So if they're like, hey, I was just at the gastroenterologist on Wednesday because they thought I had an ulcer and I had an endoscopy, and now all of a sudden they have extreme pain in their chest. Maybe during the endoscopy, the endoscope perforated the esophagus a little bit, and that led to what's now Borhave syndrome. So you should consider this in the patient who's been repetitively vomiting and drinking, and also the patient who's had a recent medical procedure involving the esophagus. So let's bring it back to those 6 life-threatening causes of chest pain. Again, that's myocardial infarction, aortic dissection, pulmonary embolus, cardiac tamponade, tension pneumothorax, and Borhave's. Now, fortunately, the pre-hospital management at the BLS level for these conditions is going to be really similar. You'll notice you're going to take every one of these patients to the hospital. For an MI, you can administer aspirin. The dose for this would be 4 81 milligram non-enteric-coated tablets, which the patient should chew. And they really should do this unless they have a hard contraindication, which would be an allergy or recent gastrointestinal bleeding or other reason why the patient says they can't take aspirin. But for most comers, they should get an aspirin. They're going to need ALS for an EKG, and they may need nitroglycerin or other interventions. Aortic dissection, you should call ALS because these patients can get unstable, but by and large, there's no intervention you can do about this in the pre-hospital setting, and you just need to use diesel and get that patient to the hospital. Pulmonary embolus. So if the patient is hypoxic and they have low oxygen level, you can give oxygen to these patients, and you should transport them to the hospital. In general, ALS should be called for these patients because it's often hard to distinguish this from myocardial infarction, and so it would be beneficial to get an EKG, but by and large, like a PE can't be addressed in the pre-hospital setting. Cardiac tamponade, again, you're going to call ALS and take to the hospital. There's not much you can do, but they should get that EKG. Tension pneumothorax, again, ALS. These patients, you can do something that can help. Put them on high-flow oxygen, that's with a non-breather, and get them to the hospital. ALS can perform a needle decompression on these patients, which can help. And Borhave's, again, you're going to call ALS. Again, it's not because they can fix the esophagus, but because they can provide fluid resuscitation, they can obtain EKG, and you're going to transport to the hospital. So really, all of these patients have an indication for ALS because all of them should get an EKG. Every single patient with one of these chest pain syndromes should get an EKG. So that's going to mean ALS. Now, that doesn't mean you wait around for ALS because sometimes your fastest EKG is the ER. And in that case, just go to the ER and you'll cancel due to proximity. But by and large, these patients need an EKG at a minimum, at an absolute minimum, part of their workup. And this is true in the emergency department. When I see patients in the emergency department, every single patient with chest pain gets an EKG within 10 minutes. 100%. It doesn't matter. The slightest chest pain, you get an EKG. And that's a really critical point I want to make to you because patients often present atypical. They often don't follow the textbook, and so you really need that EKG. Now, I told you today about 6 life-threatening causes of chest pain that I think are the most important for you to know in the pre-hospital setting. Those aren't the only cause of chest pain, okay? The list of diseases that cause chest pain is long. It's too long to put on this slide. I've listed some of them like pneumonia, cocaine, asthma, COPD, trauma, costochondritis, precordial catch syndrome, pericarditis, myocarditis. But I want to call your attention to one in particular because I see pre-hospital providers make this mistake over and over and over again. It is true that anxiety or panic attacks can cause a sensation of chest pain, of chest heaviness, chest pressure, chest tightness. However, never, ever diagnose anxiety in the pre-hospital setting. I'm going to say that again. Never, ever diagnose anxiety in the pre-hospital setting. You will get burned and someone will get hurt because of this. And I see this as a very common mistake with EMS and charts where they said, "Oh, doc, he's just anxious." I see this way too commonly in charts where patients refuse going to the hospital and they're like, "Yeah, they were just anxious. They were just having a panic attack." Here's the problem with doing this. The problem is that all 6 life-threatening causes of chest pain I just told you about, these patients always have anxiety every single time because it's the body's natural response to these conditions is to release catecholamines from your adrenal glands. They're releasing your natural adrenaline, which makes you feel anxious. It makes you feel on edge. And so all these patients with life-threatening conditions will also have anxiety. And so please do not dismiss patients just simply as being anxious in the pre-hospital setting. They really, at a minimum, need an EKG. Okay, at a minimum, and that's something that you at minimum need an ALS unit for. Like the absolute minimum workup is an EKG for these patients, and for most of them, it will probably also include, just to give you a sense, a chest X-ray, cardiac enzyme, some labs. But at a bare minimum, they need an EKG. Okay. One more time. Never, ever diagnose anxiety in the pre-hospital setting. I can't say that enough times. It's a recipe for you to miss a life-threatening condition, and so I'm going to really emphasize that. With that, have a great Thanksgiving, everyone. Look out for those patients with holiday heart or all these life-threatening causes of chest pain which may come up. As always, feel free to reach out to me with any questions, and I look forward to seeing you on the next one. Thanks.